ready?
We're ready.
Okay, so hypofunction of the adrenal gland. So in this case, all three layers of the cortex are affected. So you have to replace mineralocorticoids, you have to replace glucocorticoids. Those are the two main. For the androgen level, that it usually occurs for some women, not so much for men. We'll talk about the circumstances under which to do that. So the glucocorticoid replacement is really important. If you look under patient and family education, the family has to be involved, or the people that they lived with, so that they can also recognize symptoms of cortisol deficiency, so that they can replace or inject the person if they get into trouble. This can be a medical emergency. When I was a resident, I did see someone come into the ER and die because they did not get cortisol in an emergency situation. So very important for them to understand. They also have to learn how to adjust their own glucocorticoid when they are ill, because their needs will go up several fold during illness. They need to know when to call. So this is what's happening, and I've done this, and then being directed whether to come in or to be admitted to the hospital. So with glucocorticoid replacement, we're gonna replace what they are missing. The problem is that the variation, interpatient variation, is very wide. You can see that the listed down there for normal subjects is 2.7 to 14 milligrams per meter square per day. That's very wide. We usually start at the higher end of that range when we're replacing them. So we want to use the lowest dose that will keep them asymptomatic. And sometimes that will get them in trouble because it can leave them with too thin of a margin. But we don't want to go too high because then they'll have cushingoid type effects. So it really is a difficult replacement. So the steroid that we use is hydrocortisone. And the reason for that is that it's very bioavailable. It's about 100%, so you don't have to worry about variations in bioavailability. It has a shorter half-life. And it's very rapidly absorbed. So that makes it an ideal of the ones that we have. That's what we tend to use. And we will usually dose it 2 to 3 times a day. And the reason for that is if you look at that picture at the bottom of the page, you see the variation of cortisol throughout the day. It is highest in the morning. It starts rising at about 2 o'clock in the morning. And it rises until about 7 or 8 o'clock in the morning. And the reason why we usually tell people to take their steroid first thing in the morning is because the impact on the HPA axis is the least during that time. If you add a little bit to its highest point, it isn't going to depress the axis as much as if you gave it later in the day or in the evening. You can see that in the evening we go back to about baseline. We don't produce that much as we get close to like supper time on to bedtime. So that's probably the lowest amount we produce during the day. So the total daily dose that we start with is 10 to 12 milligrams per meter squared as a starting place. Divided into 2 or 3 doses, and that will be driven by the patient's response. And a lot of it will be based on how they feel. So if we're going to use it twice a day, we'll usually give them 2/3 of the dose in the morning and the other third later in the day, but not at night, late afternoon. And we see how they feel. If some people do better with 3 times a day, I've given you a regimen on the next page where they give a bigger dose in the morning, one about maybe around lunchtime, and then one in the little bit later afternoon. Let's see. So I talked about the advantages of the hydrocortisone is fine dose adjustment. The others don't have that. Prednisone's too long lasting, dexamethasone too long of a half-life. So the biggest problem you get into is because you give the last dose in the evening or early evening, or late afternoon. By the time they get up in the morning, they are very low on cortisol. So that's usually when people are the most symptomatic. It describes me every morning: fatigue, lassitude, mild nausea, and headache, and having to get up. That's the way I feel most mornings. It's like, I don't want to get up. But the symptoms are profound in them, and it takes them about 30 minutes to an hour once they take their cortisol to then start to feel right again. So in those folks, sometimes what they do is they will put them on a longer acting glucocorticoid like dexamethasone or prednisone. And that smooths out the variations, and they feel better when they get up. So whether you go with hydrocortisone or dexamethasone depends on the variation that the patient presents with. You can follow cortisol levels or urinary excretion of cortisol to determine the variation. The wider the variation may drive you towards the longer acting agents. The disadvantage is that people tend to over-treat with the longer actings versus the shorter actings because you can't fine-tune them as much. So those are kind of your options in replacement. Under use under circumstances, special circumstances, this is important. Under illness, their needs will go up several fold. So they should be given directions as to when you are sick, here's what you do. And usually they will tell them to increase their regular daily dose by 3. So 3 times. And do that for 3 days, and if they do not, if the symptoms don't resolve or their illness don't resolve, then that's a day where they would need to be seen by a physician. On the next page, a couple of things go together. One is that everybody who has cortisol replacement needs to have some type of medical ID. I put Medical Alert there. It is my favorite, but it's the most expensive. Here's the reason I like it. It's very ugly, and it doesn't look like jewelry. EMT know to look for it. They'll usually look for a bracelet or a necklace. The more it looks like jewelry, the more people tend to wear them, but the less easy they are to find. I like Medical Alert because it has a phone number on the back, and they keep a repository of your medical information. So it doesn't matter where you are. You can be in Changsha, China, and something happens to you. They call that number, and they can give them a summary of here are your medical problems, here are your drugs, here are your allergies, and you can get that anywhere in the world. It's pricey though. It costs the most of any of them that I know of. There's all other degrees. You can buy them for extremely cheap and wear them, and all it does is has an alert. Sometimes you can engrave on them that says allergic to penicillin, diabetic, what are the common ones? You're on an anticoagulant or on cortisol. But they all should wear them. Carrying something in your pocket or in your purse is not adequate enough because you can be separated from that. So it's better to have something on you. So Andrew, you've done emergency. So what did you look for? What did the paramedics look for?
The bracelets, necklaces, and the refrigerators.
Oh, the refrigerator. Okay. So you can get, and older folks are encouraged to do this, is to have a folder that attaches to the refrigerator that has a copy of their medical records in there, and that's really good. But how often did you find that?
Probably 3 times.
Maybe in older people. Okay. So in children, they don't necessarily do necklaces and bracelets. They might do a shoe tag or an ankle bracelet. I've seen for kids. Anything different you looked at for kids? What I recommend with kids is that they sew it into their clothes, and they do either an ankle or a shoe tag. Athletes, I usually advise a shoe tag. you can get it that'll attach to your laces. Ani, you did paramedic work as well, right?
EMT work.
EMT. So what did you all look for?
It was kind of the same with bracelets and things, and people sometimes have folders or laminated cards or whatever those.
Did you ever miss someone's medical, not a medical alert, but a bracelet because it looked too much like jewelry? He says yes. Did you ever
Not that I know.
feel like you overlooked something and found it later?
Not that I know.
Okay. All right. Okay. So so the family should be taught how to inject an emergency like Solu-Medrol or Solu-Cortef. Solu-Cortef, which is an injectable hydrocortisone. And patients should keep some in their home, several doses. It says there that people usually need them on the average of 2 to 3 times a year. We also tell them to not be too reluctant or conservative, to be fairly liberal. The body can withstand a high dose versus not having enough. So we teach the family when to use it. There are some circumstances there in the middle. An injury with substantial blood loss, a fracture, nausea, vomiting, inability to take down oral agents, symptoms of acute adrenal insufficiency. Patient is found unresponsive. Questions about those? Okay. So mineralocorticoid replacement. So this one, there's only one drug. It's Florinef. And it is a fluorohydrocortisone, very potent mineralocorticoid. Usually most people have that 0.1 milligrams per day, but you can vary it. If they're on hydrocortisone, it has some mineralocorticoid activity, and so they may get too much, so you can alter the dose of the Florinef. On the next page, people who are on dexamethasone or prednisone may require a little bit higher dose. So you can see the range there. In hot weather, we would want them to stay well hydrated, also take in an adequate salt intake. Let's see. So one of the problems comes is if you have hypertension on top of it. So looking down through there, there is a sodium restriction that goes with that. We may lower the dose of the mineralocorticoid so they're not retaining so much salt. We don't stop it though, because that keeps them with an even amount of sodium reabsorption that they may, if they get into trouble, may become sodium depleted. And we avoid diuretics and spironolactone since they counteract the activity of the mineralocorticoid. So here we're going to monitor blood pressures. So postural hypotension. So if you were going to ask somebody and assess whether or not they had postural hypotension, what would you ask them? What would they tell you? Dizzy when they stand up. So usually it's a change in posture, so it can be from laying down to sitting up or sitting up to standing. Okay, so how do you measure it? Tilt test. So a tilt test is what? So blood pressure laying down, and then what do? Sit them up. What else do you look at? Heart rate. So what should the heart rate, what would be a positive change in heart rate for a tilt test?
More than 10?
15 to 20?
Greater than 10?
I was taught greater than 10 change and sometimes you don't see it so much on this laying down to sitting, but sitting to standing. Your brain has to direct you've got to have a good sympathetic outflow for the blood vessels to respond to that kind of vasoconstriction to keep blood coming back up to your head. So that one I usually find is where I find it. Okay, good. Some of you have done that in Good Shepherd, yes? I know you have. I've been with you. Okay, so it's a good thing to practice. So serum potassium, plasma renin activity, you can see why on that because you're giving me a mineralocorticoid, so you're going to suppress renin excretion. So hypertension, edema, and hypokalemia are signs of excessive mineralocorticoid replacement. Make sense? I think if you sift through it, it all tends to make sense, logical, it flows well. Okay, so androgen replacement. So the DHEA is, if you look back on page, what is that, 3? So in the reticularis, you have DHE is produced and then converted into androstenedione and then testosterone. So in some women who have adequate replacements of cortisol and mineralocorticoid will still complain of mood disorders and decreased quality of life. So it is worth a try to give them a short course of DHEA. And that has been shown to improve their mood symptoms. You usually start at a dose of about 25 to 50 a day. It's a supplement, so it's over the counter in this country. And try it for about 3 to 6 months. If you have a positive response without a lot of androgenic side effects, you're good to keep it on. If after 6 months you do not see a good response and change in mood, then discontinue it because it isn't going to get any better. Or if the androgenic side effects are too much at either of those dosing levels, then discontinue and look for other ways to treat their symptoms. So the androgenic side effects are all those good things: oily skin, hirsutism, acne, increased sweating and odor, and decrease in HDL. Questions about those? Okay, so let's move up to the pituitary. Let's talk about growth hormone excess. So what do you know about acromegaly? Most common in middle-aged men. Okay. What else?
Enlargement.
Pardon?
Enlargement of different things.
Enlargement of skeletal structures, right? Okay. Usually caused by a tumor, right? So the treatment of choice is going to be transphenal surgical resection. The most common place I have seen these folks is in the diabetes clinic. So they commonly have diabetes if their acromegaly hasn't been treated. So in terms of, the following changes occur if the surgery's been successful. So their growth hormone concentrations will normalize very quickly, but their insulin growth factors will tend to lag behind and may take quite a time for those to normalize. They diurese pretty quickly, their swelling, tissue swelling, edema goes down quickly. Their blood sugar will respond very quickly as well and will normalize. Their vision, if they've had impairments or headaches, will improve also fairly quickly within days. And the sleep apnea, the cartilaginous overgrowth will improve, but that takes some time. So those are all good news. So when do we use medical therapy? Well, a couple of things. One is if you've got, again, an unacceptable surgical risk or a patient that refuses surgery, or if you cannot get, after surgery, you can get the growth hormone and the insulin growth factors down to normal. So those are going to be your monitoring parameters to assess the success of surgery, but also the success of your medications. The drugs are expensive. The somatostatin analogs are really expensive, as are the dopamine agonists. All of these are, in the growth hormone receptor agonist, is very expensive treatments. So the octreotide, the somatostatin analog, has been around forever, long time. Very well tolerated drug. It inhibits growth hormone secretion. So we can normalize both growth hormone and IGF-1 fairly easily. It will also help reduction of adenoma. So if you've got a non-surgical adenoma, this one will help to decrease its size. Well tolerated. There are two different forms of it. There's an IM form, and then the other one, the lanreotide, is a subcutaneous form. So they're both injectable, and patients can be taught to inject, and they're monthly, so they're not too bad in terms of taking them. The dopamine agonists, they don't work as well as the somatostatin analogs, but if you have someone who can't tolerate them, then it's one of the ones you can use. Cabergoline is the best of the group. Side effects, though, are they can be hard to tolerate. The nausea and the lightheadedness can be significant. They're dosed once or twice a week, and that's why this one is favored, because it has the longest half-life, and so it can be administered on a very minimal basis. The problem is that it does have a ceiling, dose ceiling. So once you have reached that upper limit of the dosing range, you can't get any other effect. So that's somewhat limiting for this group of drugs. Probably one of the best, and I think one of the most interesting drug in this group, but is considered because of the cost, it's usually the last choice, is the GH receptor antagonist, pegvisomant or Somavert. It's interesting because it inhibits the effects of growth hormone on target tissue. Growth hormone levels don't change, they stay up, but they can't do anything. They just circulate and live, but they can't do anything. So it decreases growth hormone effect. IGF will go down, though, and normalize on this drug. Very interesting concept. It's given subcutaneous. Liver is the main side effect, and a number of people will have elevations when they take it, but most people will come back to normal. It's recommended you don't start it in people who have liver disease to begin with. So it's kind of a third-line agent. If the other two do not work, then you go to that one, but interesting drug. Okay, page 16. I'm not going to say much about growth hormone deficiency. You're usually treating children, and because there was a phase for a while where a lot of people wanted to give growth hormone to their children to make them taller. So the drug companies, not drug companies, but insurance companies got a little bit more strict about reimbursing it, and that kind of reined it in. But you can see this in a number of reasons. One would be children who have had cancers. As kids, can sometimes be growths, have stunting of their growth, and so that's one indication. It's given subcutaneously. You calculate a dose based on their weight, and you can divide it up and give it evenly throughout the week. They usually dose it 6 of 7 days a week, so they give the kids a day off a week when they inject it. There's a ton of them out there. They have all kinds of different formulations. The most interesting one I wrote down there for you is that tevtropin. It's not an injectable, but it will shoot the drug through the subcutaneous, or into the subcutaneous space through the skin under a more high-powered jet. So those sound like, oh great, I don't have to use a needle, but what I find is that they sting more than injecting yourself. But some patients prefer it, so it is one that is an option. If you note down there under dose administration, these kids will take these drugs for years, so they're on it for a long period of time. If you look under the third bullet, you continue until desired height is reached or growth velocity has decreased to less than 2.5 centimeters, which would be less than an inch after a pubertal growth spurt. Okay, so that's your endpoint. Contraindications are low, so active malignant tumor or kids with Prader-Willi who are severely obese, which is common in that syndrome, or severe respiratory impairment because they have a higher risk of death when they take this drug. Questions about growth hormone deficiency? Hyperprolactinemia, I'm not going to say much about it. You treat it with dopamine agonist. So bromocriptine is probably one of the most common. It's been around forever, long time. It has a lot of side effects, and then there's CNS, mostly lightheadedness, headache, dizziness, nervousness, and it's fairly common. You follow it and dose it against prolactin levels. And the other one is using cabergoline, can also be used, very long-acting, sometimes preferred because of that, and you only have to dose it once or twice a week. Very similar to bromocriptine in terms of its side effects. Limited pregnancy data, so they recommend you not use it during pregnancy. Okay, questions about those two? Okay, talk about panhypopituitarism. So here you have to replace everything. So it's very interesting from an endocrine standpoint because you're replacing all of the products that the pituitary used to produce. So ACTH deficiency means you're going to have to replace them with hydrocortisone. And the principles and the approach are very similar to what we talked about in adrenal hypofunction. So I'm just going to refer you back to that. There are some subtle differences, but for the most part, it's a replacement. Very similar. You're going to use hydrocortisone. You're going to dose it 2 or 3 times a day. You're going to do the same patient education with regards to illness, emergency situations. And again, you can use hydrocortisone or you can use the longer-acting dexamethasone, but hydrocortisone would be preferred. With the thyroid, you're going to have to replace T4. You can't use TSH any longer to guide therapy, though, so you'd use free T4 to guide your treatment. Note under that first bullet, though, you don't administer it until adrenal function has been evaluated and found to be normal or has been treated. So that one may wait. You start with that standard weight-based dose, that T4 dose that we use, the 1.6 to 1.7 micrograms per kilo per day. The American Thyroid Association has come out with guidelines on how to replace these folks in monitoring. They recommend keeping the T4 in the upper end of the reference range. Worried about that if they dip below that they may become more symptomatic. So that's the reason for that. So LH and FSH. So depending on the age at which you are diagnosing male or females, then they may still be in their reproductive years. They may still desire fertility. Either a male or a female. So how you replace them, that will be factored in. So with women who are not interested in fertility, then you use an estrogen-progesterone replacement. Usually we replace them with estradiol. We use a patch because it is absorbed through the skin and bypasses first pass effect. So usually start with that. If they still have their uterus, then you will use a progestin, just like we talked about before. So all those things we talked about in OBGYN, you're going to use those same principles. They usually will cycle the progestin, though. So they may use them in the last half of the cycle, or they may use them for so many days during the cycle. So they're going to try to mimic as close to what would have happened physiologically if the pituitary was still intact. For women who wish to become fertile, we can use ovulation induction, so we can use medications. to encourage the follicular development and to get ovulation. So that's usually what they do there. Or they will use gonadotropin therapy, or they'll use GnRH agonists. Oh, I skipped the men. I don't know why I did that. Okay, so let's go back up to men. So men who have secondary hypogonadism that are not interested in fertility, then testosterone replacement is indicated. We're going to hear about that just shortly. We're going to monitor serum testosterone to guide therapy. If they wish to become fertile, then it depends on if the disease is at the pituitary level or at the hypothalamus. So at the pituitary, you would give gonadotropins to replace. If it's hypothalamic, you can use gonadotropins or a GnRH agonist. And those would be given in a pulsatile manner, not a continuous. Okay, questions about the replacement there? So for growth hormones, if you're dealing with an adult, the recommendation is you don't replace unless they meet certain criteria, and they're listed down there at the bottom of the page. So if they have a low insulin growth factor concentration or a poor growth hormone response, then you could replace. Or if their hypopituitaryism is due to damage to either the pituitary or the hypothalamus. Questions about that? So similar to what we were talking about with hypofunctioning adrenal gland is you just have to replace everything that the gland was doing. Okay, diabetes insipidus. What did you learn about that?
Polyuria.
Pardon?
Polyuria.
Yeah, pee a lot. Okay, so where does it occur? So here you have to differentiate between central and nephrogenic, okay, right? So it can occur either place. Okay, so we're going to talk about central first. So the major symptoms are polyuria, nocturia, polydipsia. So you're going to have to rule out diabetes in this case because they're going to present similarly. So our primary aim is we want to decrease their urine output because they will go a lot. And we want to increase the activity of the antidiuretic hormone. So there's three options. If they have very mild disease, then you can use a diet. You can use a low carbohydrate, low sodium diet. That's a very low solute load, and so they won't pee as much. So in mild cases, and if they want to avoid drug, then it's a good one. There are other drugs that have antidiuretic hormone activity. Chlorpropamide is an old diabetic drug, not used hardly at all anymore. Thiazide diuretics, carbamazepine, an anticonvulsant, non-steroidals. So there's an option for maybe people who don't want to use a diet but are not that symptomatic. Desmopressin, which is an antidiuretic hormone analog, is preferred, and it's extremely effective. So it can be used in any of those cases, from mild to severe. The initial aim, so this is interesting, so where we start is we want to first get rid of the nocturia so that they can sleep. So that is what we gauge our therapy. And then the daytime dose will depend on the effectiveness of the nighttime dose. So then we'll take care of the daytime once we have the nighttime under control. So this drug comes in a multitude of different dosage formulations, but most people choose the intranasal, so that's the one I chose to talk about. So we talked about starting at bedtime, titrating it upward till we get nocturia under control. And that may be enough for some folks. So once or twice a day is the usual dosing. The big problem is hyponatremia. And the problem is that once you give the drug, they can get hyponatremia. They may not be able to excrete a water load. So that's the major danger in the use of this drug. So that is avoided by giving a minimal dose that will control their urine output, but also allow them to pee as they've got free water that they need to get rid of. So measuring sodium concentrations every 3 to 4 days initially, and then every 2 to 4 months. Then once you get them on a stable dose, then it's about every 6 months. Let's see. Again, patient education, education of the family about symptoms of hyponatremia, because if your serum sodium gets low enough, you can have a seizure. Vomiting, headache, lethargy, falls are very common. Coma can ensue if your serum sodium gets low enough. You get lots of shifting of fluids in the body, and if it involves the brain, then that's where the problems come. And it says that down there that desmopressin-associated hyponatremia can lead to brain injury. Safe to use in pregnancy, they can use it long term. It's a safe drug, but it has the one big downside. Questions about desmopressin? Okay, let's talk about nephrogenic DI then. This one, usually you're looking for the cause. So you can see they're putting out, polyuria is defined as 3 liters a day in adults and 2 liters per meter squared in kids. It's a lot of pee. So most common causes are, in terms of drug, lithium is the big one. We don't use lithium a lot. We use it mostly in bipolar mania, depression, hypercalcemia in adults. So it's not that common. And then it shows in children you've got a hereditary form. So we get rid of the drugs if we can. If they're lithium toxic, we can monitor levels of lithium and try to decrease it. Hypercalcemia, so renal concentrating defect becomes apparent when you're persistently above 11. So what's normal levels of calcium in the blood? 8 to 10, 8.6 to 10.2, I think, are the range. So treatment, remove the offending agent, correct the calcium and the potassium. So it's weird, we use non-steroidals. Remember, they have big effects on the autonomous regional control of water through the kidneys, fluid through the kidneys. So by manipulating that, we can help them to get rid of or decrease their urine output. Remember, if we give people non-steroidals, we can precipitate acute renal failure. Call that back. Okay, so we're taking advantage of that effect to reverse a problem. So not all non-steroidals are the same in this regard. Indomethacin, a very old non-steroidal, is probably the most effective. So choose it over something like ibuprofen or naproxen. I thought I wasn't going to be able to get done in time. Okay, questions about these? All right. Okay, I'm going to go up and get our, is he here? Is he broken? All right, so I'll take a break and we'll come back about 10 till